Hi, everybody. Welcome. Thank you for joining us tonight for our Meet the Makers series. My name is Elizabeth Daly, and I am the Executive Director of the National Foundation of Swallowing Disorders. Our goal with the Meet the Makers series is to offer our community access to those who have created products specifically for people with swallowing disorders. This series is not meant to be promotional, but rather informational. We want to give you the opportunity to ask the creators of these products your questions, learn more about how these products help people with swallowing disorders, and make connections so that your voices feel heard among our industry partners. We thank you for joining us this evening and hope that you find this series to be helpful. The makers in this series are volunteering their time to share this information. They have not paid to participate in this series, nor was it required that they be a past or current financial sponsor of the foundation. Before we begin, I'd like to make a few announcements about some upcoming events and initiatives. The NFOSD is currently offering a $500 scholarship to an individual demonstrating excellent dysphagia volunteerism and advocacy, with an emphasis on international work being done. The deadline to apply for this or nominate somebody is the end of the month. We are also in the process of preparing for Dysphagia Awareness Month, which takes place in June. We are looking for members of our community to share their story with us to help raise awareness. And lastly, we have two exciting presentations scheduled for June that you won't want to miss. One is on a current clinical stem cell trial for survivors of head and neck cancer who have dysphagia. We'll be sending out more information on these events after tonight's webinar in an email that you will receive by tomorrow morning. For those of you who have not previously joined our virtual events, please note that you will be muted throughout the presentation. We encourage you to ask questions at any point during the presentation using the question box in your GoToWebinar toolbar. There will be plenty of time reserved at the end of the presentation for your questions. This presentation will be recorded and made available on our website. We recognize that the international time differences make it challenging for some of our global audience to participate in our live events. No ASHA CEUs are awarded for this presentation. However, we will provide a certificate of participation. We would like to recognize Bracco Diagnostics for their unrestricted educational grant that allows us to continue our webinar series free of charge, regardless of your foundation membership status. I also want to recognize and thank our educational sponsors, which include Passy Muir, Simply Thick, and Cranio Rehab. And with that, I want to provide a reminder that tonight's broadcast is for informational and educational purposes. Both the NFOSD and tonight's speakers do not intend to provide any diagnostic or treatment advice or recommendations. If you need assistance identifying a swallowing specialist, please reach out to us through email. And now it's my pleasure to introduce Cari Manypenny and Alyssa Cook of Phagenesis. Cari is a speech-language pathologist with 14 years of experience who has been part of the Phagenesis team for the past 5 years and currently is the manager of clinical development. She has been instrumental in leading various global clinical education initiatives and supporting international clinical research trials for Phagenesis. Cari is dedicated to providing clinicians with new evidence-based tools to improve the lives of people with dysphagia. And Alyssa is a medical speech-language pathologist by background and has worked in the acute care setting for over 7 years. She joined the Phagenesis team earlier this year and has transitioned into the role of clinical specialist for the US. She will be monitoring the question box during tonight's presentation. And with that, I would like to turn the presentation over to Cari and thank them for presenting tonight. So give me just a quick second here to make Cari the presenter. Oops. Here we go. So you should see a pop-up, Cari, asking you to share your screen.
Let me just make sure I get the right one. Okay, I'm just going to go in presenter mode.
Excellent. That looks
good. How do we look, Elizabeth?
Yep, fantastic. Thank you.
Perfect. Let me just lower the GoToWebinar here. There we go. Okay, so thank you, Elizabeth, for the kind introduction. It is a pleasure to be here tonight. I personally would like to thank Ed, Elizabeth, and the NFOSD for hosting us this evening. We are grateful for the invitation to introduce pharyngeal electrical stimulation to this audience. Thank you again for the opportunity to present and to each of you for joining us tonight. So as Elizabeth mentioned, my colleague Alyssa Cook is also here with us tonight. She is a clinical specialist for Phagenesis. She will be managing the chat function alongside Elizabeth during the presentation. Thanks, Elizabeth. An agenda of our presentation today. So as as Elizabeth has previously mentioned, I will present an introduction to the phagenic system for the first 30 minutes, followed by a 30-minute Q&A. So for the first half of the presentation, I will cover the company, Phagenesis, background, foundational neuroscience studies, and the mechanism of action behind pharyngeal electrical stimulation, a review of the phagenic system, safety and efficacy data, and indications and contraindications for use. I look forward to your questions in the second half of the presentation. So as an introduction and to begin this presentation this evening, I just want to say that Phagenesis is the company, Phagenics is our product, and Phagenics delivers pharyngeal electrical stimulation, which is the treatment. Our company, Phagenesis, was founded in 2007. It was based upon all the foundational publications by Dr. Shaheen Hamdi and colleagues at the University of Manchester in England, beginning in the late 1990s. Dr. Hamdi is a co-founder of Phagenesis, and he is still a practicing neurogastroenterologist today. The product Phagenics received CE mark, so that is European approval, in 2012. And we just recently received FDA approval in the United States in the fall of last year. The indications for use in Europe are for the treatment of neurogenic dysphagia, while our indications for use in the United States are for the treatment of severe dysphagia post-stroke, and I'll address that more later in the presentation. I do want to highlight that we have FDA what's called de novo classification. So for those who may not be aware, what that means is just the regulatory approval process that we went to for approval is because there are no other devices on the market. So there is nothing else on the market like Phagenics. There are no predicate devices, and this product is first to market. And then I want to highlight that this product and this treatment is safe and effective. So there are over 26 publications to date, over 800 patients studied. The product has been available in Europe for over 10 years, so thousands of patients have been treated commercially. And importantly, we're proud to say that pharyngeal electrical stimulation is part of European, UK, and German guidelines for the treatment of post-stroke dysphagia, tracheostomy care, and neurogenic dysphagia, respectively. So before we delve into the foundational neuroscience work by Dr. Hamdi and colleagues, I would first like to provide a high-level overview of the neurologic process of swallowing and how central or brain and peripheral or throat damage may impact swallow safety and efficiency. So as this group on this call knows all too well, swallowing is one of the most complex physiologic processes in the body. So I preface this slide by saying this is a very simplified overview in consideration of this audience. But to begin, as a review, information within the sensory nerve fibers of the pharyngeal mucosa, so the tissue lining in the throat, is gathered and sent up to the brain and brainstem via afferent nerve signals. This information is then processed in the brain, and swallow modifying signals, efferent nerve signals, are then sent down to the brainstem. And those modified signals are then routed to the swallow muscles to optimize the timing, duration, and strength necessary to swallow. So what happens when there is a peripheral injury such as mechanical damage, desensitization, atrophy of the nerves or muscles in the throat, in the pharynx? That can happen, for example, as a result of a patient, being on the ventilator for a prolonged period of time. That can ultimately reduce or remove those strong nerve signals up to the brain. Also, there can be a central injury, so injury, disease, or damage of the brain or the brainstem directly. So an example could be stroke or traumatic brain injury, which interferes with the receipt or processing of that information or that descending nerve communication to the muscles. And in some patients, both injury may be present. So now I'd like to transition into, so we've discussed the problem of neurogenic dysphagia, but now I want to talk you through Dr. Hamdi and colleagues' foundational neuroscience work, which led to a solution, Phagenesis. So this study here, Dr. Hamdi and colleagues discovered that cortical or brain control of swallowing is located in both hemispheres of the brain with an asymmetric bias. So there is a non-dominant and dominant hemisphere for swallowing control. In the next study, in spontaneous recovery following stroke, so when a patient heals on their own, swallowing control had transferred from that damaged to undamaged hemisphere of the brain over time, a term called neuroplasticity. Dr. Hamdi and colleagues were interested in investigating how they could potentially speed up that spontaneous recovery or help patients who do not recover. So in this publication, Nature Neuroscience, they found that an application of 10 minutes of pharyngeal stimulation increased cortical excitability, so brain excitability, which facilitated those functional neuroplastic changes in the brain. And importantly, the brain excitability persisted even after the stimulation had ended. And then the last study to highlight, Fraser, in 2002, pharyngeal stimulation with specific treatment parameters, which are still used in practice today, produced not only the largest brain excitatory effect, as validated all of these studies through brain imaging studies, but importantly showed a causal relationship between brain excitability and improved swallowing function, specifically swallowing timing and safety. So if we put all of that together, how does pharyngeal electrical stimulation work? So first, the patient receives a very low level of energy, 5 hertz of stimulation to the sensory nerves in the throat. The stimulation is patient specific and it's optimized prior to every stimulation session. That personalized stimulation then triggers those powerful afferent signals up to the brain to excite the brain and facilitate those neuroplastic changes where undamaged parts of the brain are taking over swallowing control. So facilitating, speeding up that natural spontaneous recovery, those neuroplastic changes in the brain. And then downstream, what we see are improvements in a wide range of swallowing outcome measures observed in our clinical studies and anecdotally reported in commercial use. So it's reestablishing now that neurologic loop and now reestablishing that afferent output signals from the brain to the brainstem and to the muscles. So next I'd like to introduce you to the product. The product is comprised of a catheter and a base station. So I'm going to take you through the Phagenesis catheter first. The catheter has 2 parts and 2 functions. So the outer sleeve of the catheter delivers the pharyngeal electrical stimulation treatment, and the inner core of the catheter is a nasogastric tube. So it also allows for enteral feeding if required. So I'm going to take you through the outer sleeve first. So these are the components of the outer sleeve of the catheter. I hope you can see my cursor. I think you can. There are 2 bipolar electrodes positioned right here with specialized wiring that is triple sealed and insulated. The wiring runs through the outer sleeve of the catheter and it connects to a smart chip feature that is housed right here in the catheter. We have nasal guides and oral guides. So these two positioning guides allow optimal confirmation, number one, that the electrodes are in the right position, and also that the distal end of the catheter is in the stomach if used for feeding. The treatment catheter also allows, it works with the base station. Here's where it connects. It allows for optimization, so personalization of the patient's stimulation levels, delivery of treatment, and electrode contact monitoring. The inner core of the catheter, these are the features of the inner core of the catheter. So as I mentioned, it's a feeding tube, an 8 French fine bore feeding tube, so you can feed the patient while also treating them. There's a guide wire to facilitate rigidity of the catheter during placement, and our nasogastric feeding tube portion of the catheter is compatible with both ENFit and Luer feeding sets, which are the most common feeding sets. Mainly ENFit is most commonly used in the United States and Europe. I'd also like to highlight the catheter makeup. So it is a polyvinyl chloride and phthalate free. So these are chemicals used in the production of plastics. They are not found in our catheter. It's also latex free. It's BPA free, which is another chemical. And it does have barium sulfate radio opacity, so that if you do X-ray imaging for confirmation of the catheter, you will see it on the X-ray. But to highlight, no chemical toxins used in the makeup of our product. To transition now to the base station. So the base station is a very simple, easy to use touchscreen interface. It takes the user, the Phagenesis treater, through stepwise treatment level optimization so that you can tailor the treatment level to that patient's specific sensory capacity and their individualized needs for that treatment day. As mentioned with our catheter, it connects right here. It allows for continuous electrode contact monitoring. So it will notify you and potentially pause treatment if contact is lost. And it's smart. It retains all patient and operator information in the database, which can be exported if desired. Okay, so putting it all together, we have the Phagenesis system. So it's a dual function catheter. It's a treatment catheter that has 2 parts and 2 functions. So treatment catheter for delivery of pharyngeal electrical stimulation, but it also has that dual function where the inner core is an 8 French nasogastric feeding tube. Once the catheter is placed on day 1, it remains in place for the treatment duration. But it can be left in place even after treatment is complete if the healthcare provider still needed to use it to deliver enteral feeding for up to 30 days. The base station over here is, as I mentioned, intuitive software, guides the user to measure the patient's sensory capacity prior to every treatment session. The base station then automatically calculates the patient's personalized stimulation level. There is a feature allowing the clinician to test the stimulation level to ensure patient comfort before proceeding on to the 10 minutes of treatment. So the treatment process is a simple 4-step process. So on treatment day 1, you would adjust and insert the catheter. And when I say you, that is completed by whoever at the institution, whether it be the hospitalist, nursing, mid-levels, physician of any type, whoever is most trained and certified at your institution to place a nasogastric tube would place our catheter. From there on, the catheter remains in place. That's when typically the speech language pathologist, or I know we have other countries on the call, so the logopedist or the speech and language therapist, then comes in. They connect the catheter to the base station when they're ready to treat. As you can see, it's connected right here. They follow the on-screen prompts to measure the patient's sensory capacity and optimize the treatment level, and then they begin stimulation. So treatment is 10 minutes once a day for 3 consecutive days. You can apply a second cycle up to 6 days of treatment in total. I get a lot of questions about electrode positioning. So the foundational studies use brain imaging to optimize the therapeutic target region in the pharynx, in the throat, for pharyngeal electrical stimulation. As I highlighted before, the nasal black and oral green positioning guides, which were based upon average adult anatomy ranges, ensure correct placement of the catheter. So to confirm the electrodes in their proper position in the pharynx, as shown above, and I've got a little animation here. When the stimulation is being delivered, you can think of it almost like an olive. It's not so focal, it branches out and hits many regions within the pharynx. And for the clinicians in the audience, the low level energy that's being delivered to the pharyngeal mucosa, we're specifically targeting cranial nerves 9 and 10, those sensory nerve fibers. And as mentioned, it is adjustable to meet various adult anatomies, and it measures electrode contact throughout the duration of treatment. Here's another image of the catheter in place. So we've got our black nasal guides, which are positioned right here outside the nose. We have our green oral guides, which you can see in our model, are right here. And then we have our electrodes, which are the blue arrow. So we have the electrodes positioned right here, and then this is a video fluoroscopic image of the electrodes positioned in a patient. So treatment timing. So the 10 minutes of treatment is based upon foundational dose optimization studies. All of actually our entire treatment dosage is based on foundational studies, multiple studies that validated the optimal treatment for cortical excitability and swallowing improvement. When the clinician comes in, level optimization takes about 10 minutes, but once you get really competent, it could even take about 5. Treatment delivery is 10 minutes of time. So the standard treatment regimen is 10 minutes per day for 3 consecutive days. Then the clinician can reassess the patient to determine perhaps if a second cycle is needed. So a subset of patients may require up to 6 days of treatment. And all of this, again, is based upon clinical studies that have shown that 10 minutes per day, once per day for 3 to 6 days provided significant clinical benefit in patients with severe dysphagia post-stroke. To introduce you to our clinical evidence and safety profile. So this overview here is showing all the clinical studies published to date. So there are 26 publications and counting to date. There are quite a few in the works right now. 8 randomized controlled trials. Phagenesis has been studied in 14 countries. As mentioned, it's been in routine clinical use for the last 10 years in Europe, and we just now are introducing it to the United States, and it is a part of various guidelines, treatment guidelines, dysphagia guidelines. Importantly, there have been 0 serious adverse events from Phagenesis stimulation in any study or in real-world use. So there have been no serious adverse events related to the stimulation at any level. There are a few rare, non-serious side effects that have been reported. So an example would be like jaw chattering or maybe momentary ear pain if the electrodes are not quite positioned properly. But once repositioned, it's readily reversible. None of those side effects persisted. Treatment is well tolerated by patients. So I often get questions, what does this feel like? I have asked patients, what does it feel like? And if they're able to verbally communicate and describe it, they've said things like it feels like it's tingling or like a pulsating sensation. One guy said it's like a pop, pop, pop. Or some patients have reported that they feel nothing at all. So they're stimulated at the highest level. You know, they're so severe to profoundly impaired, desensitized, they don't really even feel the stimulation, and they're pretty relaxed during the therapy. Some of the folks in our company and users, physician and speech pathologist users in Europe have actually stimulated themselves so that they could get a feel for the therapy before giving it to their patients. And lastly, the device has been rated very easy to use. So as part of our FDA submission, I did run a usability study with various healthcare providers undergoing, our standardized training and competency program, where they had to go through the training and had to rate various aspects of the training and device usage. There were no issues that arose in that program, as well as our largest clinical real-world registry study. An N of 255 patients were treated there. They also captured the ease of use from the healthcare providers delivering the intervention. And again, the software was very simple and there were no issues. If you're interested in reading more about our publications, in the attachments to this presentation, we have submitted our clinical evidence bibliography with all of the publications to date, and all papers are hyperlinked if you're interested in reading more. So patient selection, as I mentioned, we just got FDA approval. We in the United States are approved to treat patients with severe dysphagia post-stroke. So what does severe dysphagia mean? The FDA have determined that this can be decided by the healthcare professional, by the speech-language pathologist. However, as an aid to properly identifying the patients that are going to be most appropriate and benefit from this intervention, I've tried to synthesize outcome measures from our various studies to guide clinicians in how to select the right patients. So those that have reduced or no spontaneous swallowing, poor laryngeal or pharyngeal sensation, so not feeling things going down the wrong way, not feeling when things are kind of sticking in the throat. Patients are likely going to be NPO or have a significantly modified diet. As part of our training and onboarding process, myself, Alyssa, our colleagues in Europe partner with our clinicians as they're learning about this system, and we help you to select what patients are going to be most appropriate. Now, our indications for use in Europe are slightly different. So the indication in Europe is a bit wider. It is for the treatment of neurogenic dysphagia. And generally, you're going to be selecting patients with a similar description as I mentioned before. So contraindications and warnings. So Phagenesis treatment is contraindicated where it is not possible to place a standard nasogastric tube. So if a patient has an anatomical abnormality or maybe significant stenosis and the like, if you can't place the catheter, a nasogastric tube in the patient, then you wouldn't be able to place our catheter. Our treatment catheter should not be used where insertion of a catheter into the throat may have an impact on the patient's respiratory status. So if this were the case, if your patient had severe heart failure or end-stage COPD, you'd want to consult with the medical team on if this was appropriate. Patients who have any implanted electrical devices or any invasive devices with active electrical components that can't be removed during treatment, so such as like a pacemaker, a deep brain stimulator, would be a contraindication at this time. Phagenesis should not be applied in pregnant women or children. It has not been studied in those populations. And as a general warning, our catheter at this point in time is not MRI or defibrillator compatible, so it would need to be removed in those circumstances. So while there is data to support the early, intermediate, and late use of Phagenesis to treat neurogenic dysphagia, we do encourage the early use of this intervention modality. So when dysphagia risk and health complications to the patient may be most critical. I do want to highlight this is an adjunctive therapy, so we are not replacing anything that is out there on the market or different muscle rehabilitation strategies that clinicians are using. This is meant to complement traditional muscle rehabilitation interventions. One advantage of the Phagenesis system is that it does allow for early treatment So it can be used in patients who may not be able to actively engage in traditional rehabilitation methods, or who maybe have not responded to traditional therapies. That may be a time where you want to also consider Phagenesis therapy. Because minimal patient involvement is really required. And I like to think of this intervention almost as like priming the neurologic system to be completed prior to or in addition to muscle rehabilitation. So everything else that clinician may be doing with their patient. So as an overview, Phagenesis treats the root cause of neurogenic dysphagia. This therapy is not a this therapy is a nerve stimulation. It is not muscle stimulation. No surgery is required for this intervention. The therapy is delivered 10 minutes per day for 3 consecutive days and up to 6 days. The catheter remains in place for the duration of treatment and can stay in place up to 30 days if the nasogastric feeding tube portion is used. Minimal patient involvement is required. No active exercises are to be completed during stimulation. The catheter is a dual action catheter, so it supports both treatment and feeding. This therapy is brand new to the United States, but has been commercially available in Europe for over 10 years. And importantly, it's safe and has been shown to be safe and effective. So over 800 patients studied to date and counting, 26 publications, 8 randomized controlled trials. There have been no serious adverse events. There have been significant improvements in a wide range of dysphagia outcome measures. Many of the studies have, of course, used instrumental assessment, whether that be FEES, flexible endoscopic evaluation of swallowing, or video fluoroscopy, X-ray of swallowing, and various measurements and feeding scales have been used. Additionally, we do have some health economic data as well, showing that treatment responders and also in randomized controlled trials compared to control or no treatment showed reduction in hospital length of stay, and data also to support improving swallowing function to enable faster decannulation, tracheostomy decannulation with persistent benefit, no recannulations required. And to support safe and effective use of our product, we do offer a standardized training and competency program where myself, Alyssa, our European teams physically come on site free of charge, and we train your medical team in how to properly deliver this therapy, select the right patients, and support you in initial patient cases to make sure that you are delivering safe and effective therapy to the patient. I just want to highlight on our website, if you are interested, since there's so much I would like to share, but 30 minutes isn't always enough. We do have an animation video here that kind of takes you through an overview of the treatment, and then also a setup video, which actually kind of shows placing the catheter and how to actively use the device, the Phagenesis system, to optimize treatment levels and deliver treatment. So if you're interested, hop on over to our website where you can watch those videos. And just to, in closing, kind of wrap up, I just wanted to highlight the European guidelines in the United Kingdom where pharyngeal electrical stimulation is recommended. So in 2020 and 2023, tracheostomy care and stroke dysphagia care, as well as European and German guidelines for the treatment of neurogenic dysphagia and post-stroke dysphagia. So if you have any questions, I think we are ready to open up the forum for the next 30 minutes, and I'm happy to answer any questions that come to mind. Thank you.
Hi everyone, so my name is Alyssa. Cari introduced me earlier. I've been kind of answering some questions offline, but I'm gonna bring quite a few to Cari. So Cari, first of all, what kinds of things do you do during treatment? Do we recommend swallowing exercises or boluses, or what should we be doing while we are doing the treatment?
Yeah, that's a great question. Thank you. So this is more of a passive treatment. So you are optimizing the stimulation level for that patient on that day. And during active stimulation, the 10 minutes, you should see the patient actively swallowing. I think one of our patients recently swallowed nearly 150 times during the 10 minutes of treatment. But you do not need, nor do we want you to do exercises during the stimulation because we want the electrodes to stay properly positioned. However, use this as a primer for your patient and do the intervention followed by maybe your therapeutic trials or your exercises, whatever is appropriate in that care plan.
Perfect. Another question was, should you use this or can you place this alongside another Dobhoff or an NG tube, or do you recommend, or is it you have to remove it and then reuse this instead?
You can place it alongside another Dobhoff. That has been done many times. So it's really up to the choice of the medical team. You can remove the NG tube that is there and place Phagenesis, or you can place Phagenesis in one nostril and leave the Dobhoff in the other.
Perfect. We're getting some questions about, does it matter the site of the stroke, brainstem versus cortical? And then also we have some questions about any studies with head and neck cancer.
Great question. So the first question to address like lesion location, there have been some sub-analysis and meta-analyses of our publications looking at lesion location from a perspective of right versus left hemisphere. There was no difference in a post hoc analysis. Also, patients with ischemic or hemorrhagic strokes, no difference in outcomes, both can improve. And lastly, cortical, subcortical versus like brainstem or cerebellum involvement all have been included in our studies and have been shown improvements, have been able to show improvement. The next question I think was about head and neck cancer. That is a patient population that is near and dear to my heart. I've talked to Elizabeth about it before. My dad is a head and neck cancer survivor. He also has Parkinson's disease with dysphagia. So I'm also a speech pathologist at home. I know that we are always looking for solutions for that specific patient population. Unfortunately, to date and to my knowledge, we do not have any data specifically in the head and neck cancer patient population. Most of our data has been in neurogenic dysphagia as a result of stroke, brain injury, and the like, and also some non-neurologic causes, maybe like patients who've been ventilated a long time after a cardiac event or septic, sepsis, things of that nature. But to directly answer your question, we do not have data in head and neck cancer at this time.
In this similar vein, Cari, we're getting also some questions about other patient populations such as Parkinson's, anoxic brain injuries, and also chronic dysphagia in general.
Yeah, so a segment of our patient population in the PHADER study, so that is our registry, it was an N of 255 patients. A segment of that did include patients with anoxic brain injuries grouped in. I am not able to speak, to my knowledge, to any publications, including the Parkinson's population. Again, as I mentioned, population near and dear to my heart as well. But there is data in Europe for the treatment of multiple sclerosis, patients with Guillain-Barré, patients with COVID. So those are not approved indications at this moment in time in the United States. However, those patients are absolutely being treated in Europe. Did I answer all the questions, or was there one I missed?
No, I think you have all of them.
Perfect.
We're getting a lot of questions about cost. I know we have a lot of different demographics and locations on this call, but can you give a response to that question, Cari?
Yeah, no, thanks for that question. I understand why it's being asked. We do have a really diverse audience on this call representing many regions around the world, which is super exciting, but I don't think it would be prudent for me to provide numbers that may not accurately reflect the therapy's value in specific markets because there's We have variations in like reimbursement policies, insurance infrastructure. So what I would suggest is if you want to learn more about our pricing program in your region, we are absolutely happy to have a direct conversation offline. Alyssa will put in the chat, if you wouldn't mind. Anil Kenny, he's the VP of Global Marketing at Phagenesis. So I think you have his email in the chat, or you can also reach out to him on our website, the contact. Anytime you hit the contact, Anil's going to get that. Anyways, and please, if you do reach out about pricing and you want more information, reference that you were part of this call today so that Anil can prioritize your question. I do want to highlight just very quickly, if I may, that we do have something that's exciting in the United States, specifically in acute care hospitals. We have a special designation from the FDA. Without getting into too much detail, we are going to have a reimbursement program that we have qualified for 3 years, where 67% of the product cost will be reimbursed to the hospital for our first 3 years in acute care center usage in the United States. But I'll leave Anil to talk about pricing further if you have additional questions.
And I'll add that contact information to the chat in just a second. Cari, we're getting some questions about Vital Stim and how is this similar or different than Vital Stim?
Yeah, another great question. I do have a little slide. I wonder if I could share it or not. I guess just to briefly highlight off top of mind the differences between pharyngeal electrical stimulation and Vital Stim. I would say number one, we're intending to treat more like the root cause of the neurogenic dysphagia, whereas Vital Stim, their sort of mechanism of action, their description is more muscle re-education. So they're trying to facilitate muscle contraction, where we're trying to facilitate those neuroplastic changes. The stimulation target is different. So in pharyngeal electrical stimulation, the stimulation is being applied directly to the pharyngeal mucosa in the throat, whereas neuromuscular electrical stimulation, the electrodes are typically right outside, placed on the outside of the skin, typically in the submental region, but I do think there's also variations depending what company. From a dosage standpoint, our treatment, Phagenesis, is 5 hertz as opposed to maybe, I think it's a range of about 30 to 80 hertz for neuromuscular electrical stimulation. Our intervention protocol is 10 minutes per day for up to 6 days. I think pending the company, for neuromuscular electrical stimulation, it can be 30 to 60 minutes a day, maybe 3 to 5 days a week. So I do want to clarify that we don't see any of the neuromuscular electrical stimulation companies as a competitor. If anything, it could be complementary. It's really just what is most appropriate for the patient. Even though both are giving a form of electrical stimulation, we do not see ourselves being the same. Our goal and intention behind the therapy, the mechanism behind therapy is different.
Perfect, Cari. I'm doing a lot of things. This is much more
You're multitasking
than I thought it would be. Specifically,
Elizabeth then too.
yeah, some specific US clinicians are asking how do they get information, what kinds of sites are we looking for currently, and then how do they kind of follow up with us if they're interested in kind of chatting more with us?
Yeah, perfect. We'd love to hear from you. So just as an overview, like right now, we are looking to partner as our initial rollout in the United States. I mean, we just launched last month in our first institutions, but we are looking to partner with large comprehensive stroke centers. So I would say a minimum treatment of about 500 strokes per year. So we're looking to partner with large comprehensive stroke centers in our first year. We are currently offering in the United States a free of charge clinical evaluation for early adopters that we partner with, where we will actually give you a base station and a certain number of catheters for free, do the training for free, select the patients and partner. all free of charge to get your the U.S. experience. You know, this system has been in Europe for a while, but many U.S. clinicians haven't heard of us yet. So if you are interested, if your hospital meets that qualification, and I will say we are tending at this point in time to partner with acute care hospitals and long-term acute care hospitals. But if your hospital meets that criteria and or you're interested in learning more, again, I'm going to steer you over to Anil Kenny and reach out to him, reference this webinar, and we can prioritize your inquiry and get in touch with you.
Perfect. In the presentation, you were describing some significant swallowing improvements. Can you describe some of those outcomes that Phagenesis shows benefit to?
Definitely. And I will say that we do have a whole clinical overview presentation, which actually thoroughly goes through the clinical evidence. There's a lot of information to digest, so I did create single-page summaries of all of our publications to date. But as a high level, to just speak to it, I mean, there's a wide range of outcomes, whether it be penetration aspiration scale score, swallow timing measures. There's scales looking at secretion management, spontaneous swallowing, laryngeal sensitivity, and cough in the tracheostomized patient group. We do have outcomes. So all of those are obviously instrumental assessment fees or video fluoroscopy used. We do have outcome measures in various feeding scales. So one being the FOIS, the functional oral intake scale, or in Europe, they commonly use what's called the dysphagia severity rating scale. So these are scales measuring if the patient's able to eat by mouth and to what consistency, perhaps what supervision they need, or if they need enteral feeding, for those who are not familiar. And then we do have a few studies also looking at health economic outcomes. So there's a wide range of dysphagia, swallowing, secretion management, and health economic outcomes in our studies. If you are interested in learning more or hearing that clinical overview presentation, please get in touch with us. We're happy to schedule a follow-up to this. And we have hyperlinked our bibliography with all 26 publications listed. You can click them and it'll take you to the abstract or the full text paper.
Perfect. In regards to timing, so how quickly are we doing this intervention? And then also how quickly are you seeing changes and how long do they last?
Okay, let's break that one down. So the first one is timing. So
yes.
you can administer this therapy as early as 24 hours after there's 24 to 48 hours after their stroke, if appropriate. Okay, break down the questions again for me, Alyssa.
Perfect. How quickly do you see an improvement potentially in a patient?
Yeah, so pretty immediately, you should generally, maybe not all patients, but many, you'll see increased spontaneous swallowing during active stimulation and perhaps improved secretion management. Most of the outcome measures in our clinical research studies were measured 24 to 72 hours after the final treatment session. So we would hope that there would be some advancement. Now, I want to be realistic. This is not like some magical device that cures everything. You're not necessarily going to go from NPO for a certain amount of time up to eating a steak again. There should be a slow incremental change within that 24 to 72 hours, but you should still observe your patient even that week or two thereafter, where some additional change, additional effect will be observed. Now, again, this isn't replacing anything you're doing. This is an adjunctive therapy. So, of course, if the patient requires any additional interventions, continue on with the appropriate protocol for that individual person. Did I answer all?
That's okay. I'm with you. How long do these kind of improvements, these effects last?
Yeah. So. Yeah, they should be long lasting. We have not seen any regression. So a patient has not improved after this therapy and then regressed or declined. I can tell you from a clinical research perspective, nearly all of our studies have followed patients at least 30 days or up to hospital discharge, sometimes longer. For the tracheostomized patient population in particular that have been treated with this intervention, if they were able to be decannulated, none of the patients required recannulation. So even though this is a rather temporary therapy, it is a permanent effect. And that is also evidenced in the foundational work from Dr. Hamdi and his group. They found that when they did the brain imaging, even after the stimulation had ended, those changes persisted over time. Did I get them all?
Yes, you did. Thank you. Let's see here.
Great questions, everyone. Thank you. And if we don't get to all of them, I know we've got about less than 10 minutes left. Please, contact us through Elizabeth, through our website. We'll happily address any questions you have.
Cari, we're getting some questions from international SLPs, SLTs, etc., that are asking, where is this located? This one question specifically is for, are we located or are we available in Australia?
So we currently have regulatory clearance in Europe and the United States. We do not currently have regulatory clearance in Australia. However, if you are interested in bringing this therapy to your market, again, I'm going to hand you off to contact. I'm going to advise that you contact Anil Kenny, our VP of Global Marketing. He can triage you to the appropriate person. Yeah, but right now we only have regulatory clearance in Europe and the United States at this moment in time.
Cari, how does this affect decannulation in trach patients?
Yeah, so obviously a decannulation process, there are many criteria that needs to be in place to enable safe and successful tracheostomy decannulation. What we are saying is we, in randomized controlled trials, single center studies and randomized controlled trials, what we have shown is an improvement in different criteria. There's a validated scale that they use in Europe. May not be as familiar in the United States or other regions. However, the criteria of this scale is very common in things that we look at in fees to assess a patient's, spontaneous swallowing, secretion management, making sure that they're not silently aspirating, secretions, laryngeal sensitivity and cough, things of that nature. So if the patient was able to meet a certain 3-part criteria in terms of improving their swallow function, they were deemed ready for tracheostomy decannulation. But of course, you have to consider the patient as a whole if there, other variables. But from our study perspective, those were the criteria that is approved.
Perfect. Thank you, Cari. Because we only have time left, and I feel like a lot of people are kind of asking this question / thinking about this question, and because I know you can answer it, how are we teasing apart spontaneous recovery?
Yeah, no.
Our randomized controlled trials, obviously.
Yeah, no, I mean, that's challenging, right? I mean, yeah, we do know that a subset of patients will spontaneously recover, especially after a stroke. The way that the company, and I should have prefaced this earlier, in our clinical evidence, we do have Phagenesis company-sponsored studies, but there also have been many independent studies independent of the company. So in general, the way the studies were designed were that they were randomized controlled trials, where of course half the group, both groups got the Phagenesis catheter placed, half the group actually got active stimulation, the other half had sham or control, so they got no stimulation. The patient groups were matched, so they were similar, and then they tested the outcomes over time, and that was the way in that study designed to account for the patients that may spontaneously recover. Obviously, we know in our everyday clinical practice, sometimes you can get a feel for the patients that, you think, give them a couple of days, they're going to recover. those are the patients that you're probably not going to select for this therapy. You're going to select this therapy for the patients that you're concerned you're going to need to place a PEG. They can't even manage their saliva, their secretions, they're suctioning all the time, they're not spontaneously swallowing. Again, like you're thinking about a PEG placement, let's intervene early on those types of patients. I hope I answered that question adequately.
Thank you, Cari. Elizabeth, do we have time for one more, do you think?
Yeah, go for it. I think that sounds good.
Perfect.
I'm here all
night. How late post-stroke onset, or what is our research showing for kind of not so acute strokes?
Yeah, so to be honest, most of the data is within the first 4 weeks of the stroke event. However, we do have data in patients who were, let's say, 7 weeks post, an average, it could have been longer, 7-week stroke, they hadn't improved at all, Phagenesis was applied, then they showed improvements. We do have one small randomized controlled trial. It's the Michaud study on the bibliography, where those patients were 1.5 on average, 1.5 years post-stroke, where after treatment they were still able to show some degree of improvement. So most of our data is in more of the acute phases. However, we do have some data in more persistent, difficult to treat or chronic patient populations.
Thank you, Cari.
Chronic dysphagia. The patient's not. The patient's not.
I keep responding to a lot of you that our bibliography is attached. There are handouts attached if you go to your control panel, and I know Elizabeth will also send them out along with our kind of, if you want to repeat watch this webinar as well. So they all are there, and they're also hyperlinked. So if you click them, it'll bring you directly to the paper.
Actually, that's a really good point, Alyssa. So not only what Alyssa said and what I've been mentioning, the hyperlink bibliography, we've also uploaded our patient family brochure. We've uploaded a document that is a pamphlet about how dysphagia is common, harmful, and costly, and how Phagenesis can help be the solution to treat neurogenic dysphagia. We have also uploaded, lastly, a YouTube video with one of the speech and language therapists in the UK who uses our intervention regularly. She's a commercial user using our product, and we have an interview of her kind of commenting on the real world use of the therapy. So if you're interested, check those out as well.
Excellent. I'm going to sign on and join you here. Yes, that was the fastest hour. My goodness. I want to thank you both. Alyssa, I'm so glad you were on the call tonight to field all these questions. I've been hosting these webinars for almost 10 years now, and I've never seen so many questions come in so quickly and so many different questions from such a wide audience too. We have speech language pathologists on the call. We have people with severe dysphagia. We have care partners that are joining us tonight. So it's clear that there's an obvious interest in new technologies, new treatments. And I think it's rare for us to be able to present on some of these novel treatments. And I think it really inspires a lot of hope, both in clinicians and people living with dysphagia. I know there's people on the call tonight that are NPO after a stroke with severe dysphagia, and their management plan is a feeding tube, and that's unacceptable. So to hear some of this information, I think is probably inspiring and provides a little seed of hope for some of the people on the call tonight. So thank you for presenting this information. We hope to have you back again in the future to give us updates as your clinical trials expand and we learn more about this.
Yeah, definitely. And Elizabeth, thank you so much for inviting us. This is such a great forum that Ed, you, and the NFOSD have put out to connect us with individuals with dysphagia, caregivers, and healthcare providers across the globe. Really, I was super impressed with how many folks are part of the NFOSD. So we really appreciate this opportunity. And of course, want to stay connected with anybody who watches this live or recording. Please reach out to us. We're happy if we didn't get to your question. We're happy to speak with you at a later time.
Excellent. Thank you. And with that, we'll kind of wrap things up. I'll be sending out an email momentarily. It will have a link to a survey. And if you attended this evening, we would love for you to fill that out. It's very brief, it's anonymous, it should take less than 3 minutes, but it's very helpful for us for planning our future webinars. And we will share the feedback too with Cari and Alyssa. I'll send out an email that also includes some links to our upcoming events and initiatives too, and that way you'll have our contact information. I'll also include all of the handouts and the links that you provided tonight too during your presentation. And so with that, everybody, I'd like to thank you for joining us. Alyssa and Cari, thank you so much for presenting, and hopefully we'll see you back in June, everybody. Take care.
Thank you.
Bye.